All. This is Dr. Mubin Sayed from drbeen.com. Welcome to one more show. So today we are going to go over the US Preventive Service Task Force statement about the aspirin recommendations that they have just published this month. So let's start. So this is the PDF. All the links that you would see here are in the description of this video. This is the PDF, aspirin used to prevent cardiovascular disease, US Preventive Service Task Force recommendation statement. Now, just very quick view of the link. So this is drbeen.com. This is a calculator. So in the discussion today, you would see that the task force in their recommendation would say that if somebody has the cardiovascular diseases risk in 10 years of 10%, then do the following, or 10% or greater. So then the question becomes, what is that risk of 10% mean? So I have this calculator or estimator open here. This is American College of Cardiology. This is actually a combined calculator with American College of Cardiology and American Heart Association. And this calculator is also mentioned in the recommendation statement. So we will actually use this calculator to calculate the risk and then use that risk to see how the recommendations are. Then this is the actual recommendation website. I found that the PDF was actually a better one compared to the website. It's a beautiful website, but searching or navigating this is just lots of pain. Same thing with some more data here. This is JAMA and their card. Their write-up about this recommendation, some more about that, and finally, what are the hemorrhagic strokes and so on. So with this background, let's start. So these are our gifts for humanity. So because this recommendation is a sensitive matter, I'm going to use as many excerpts from the text as possible so that we stay very tightly within the recommendations language. So here is what they're saying. This is from their recommendation PDF. Sorry about this little. So they created a micro simulation model. In that model, they added various variables for risk of cardiovascular disease, and then various studies that had been looking at the risks over 10 years or 20 years, and then they came up with the results. So this is what they are discussing here. Modeling data estimated that aspirin use in both men and women aged 40 to 59 years with 10% or greater 10-year CVD risk. I will explain these all. Generally provides aspirin use a modest net benefit in both quality adjusted life years and life years gained. What they're saying is, in more simpler terms, non-medical terms, that usage of aspirin in this age range can provide modest benefit for quality of life improvement and the years of life gained. So initiation of aspirin. So now please remember, this recommendation is not for those who are already using aspirin. This is for those who may start aspirin. So initiation of aspirin use in persons aged 60 to 69 year results in quality adjusted life years gained that range from slightly negative to slightly positive depending on the cardiovascular disease risk level. And life years gained are generally negative. And I'll show you the table. What they're saying here is for the 60 to 69 years of age, use of aspirin is actually trending towards negative life years gained. So they're saying that there is as slightly negative to slightly positive, but life years gained are generally negative. That means there is harm that may be associated with aspirin in this age range. In persons aged 70 to 79 years, initiation of aspirin use results in a loss of both quality adjusted life years and life years at essentially all cardiovascular disease risk levels modeled. So if the aspirin is started at this age, then the quality of life actually becomes less good because the aspirin might cause bleedings or increase the bleeding tendencies, or other side effects would occur. So this is their modeler. Based on this model, they made some recommendations. And why is this important? So they're doing this update after 2016. Why is this important? They're saying that cardiovascular disease is the leading cause of mortality in the US, accounting for more than 1 in 4 deaths. Each year, an estimated 605,000 people in the US have a first myocardial infarction, and an estimated 610,000 experience a first stroke. Now, there is another important thing to keep in mind. These recommendations are for primary prevention. What does that mean? That is, if somebody already had cardiovascular disease, for example, a myocardial infarction, a cardiac event, or cerebral event, some stroke, or peripheral vascular disease, for example, deep vein thrombosis or others, this recommendation is not for them. So it is not for those who are already using aspirin. It is not for those who are at a risk of secondary attack, that is, they have already experienced cardiovascular disease. It is actually for those who have not experienced a cardiovascular disease and who are healthy and who are thinking about using aspirin with their doctor and whose age is more than 40 years and above. So what are they talking about? What are they saying? So I'll present the summary and then we'll go over some of the data that they have. So one more important thing here. This is about the low dose aspirin. This is not about high dose aspirin. And how are they defining the low dose? From their point of view, from the document's point of view, they are defining low dose as lesser than 100 milligram per day. And at one other point in the document, they say 81 milligram per day is a reasonable drug as well if you are going to initiate. So they're talking with the physician about the patient. So it is low dose aspirin. From a mechanism point of view, what is the difference between low dose and high dose? Low dose aspirin would only block cyclooxygenase enzyme 1, COX-1. Remember, we had a discussion about aspirin in the past as well, and we discussed that there are two enzymes, cyclooxygenase 1 and 2, and aspirin has an effect on both of them. However, in the low dose, it only has effect on cyclooxygenase 1. And they are talking about the recommendations for low dose aspirin usage. So, continuing, it is important to note that the net benefit of continuing aspirin use by persons in their 60s or 70s is not the same as the net benefit of initiating aspirin used by a person in their 60 or 70. This is a very important point, and they further explain it here. What they're saying is, if somebody is in the age range of 60 to 70, and they're already using aspirin, then it may be because they were started on aspirin because of some risk factor and probably started earlier in their age than 60 to 70. And if that is the case, then it is important for them to discuss with their doctor and continue if necessary, because they may have a higher risk. That is why they were taking the aspirin. However, if this is the age range and they are going to initiate the aspirin, then the benefit is not similar as someone who is already using the aspirin. So what is the takeaway? The takeaway is this recommendation is for someone who is thinking of starting and not for someone who's already on it. That's one. Second, this is for those who are going to start this for primary prevention. So this word, the words, primary prevention, that is the first time possibility of cardiovascular disease. Okay, so what is the change? What are they saying? There are two diseases, generally big groups, that they looked at the trials for, the studies for, the data for. One are the cardiovascular diseases, which can mean cardiac vascular diseases, for example, coronary artery diseases, or cerebral strokes or brain's vascular diseases, or, for example, legs and the vessels in the legs diseases, or peripheral vascular diseases. That all is grouped together in cardiovascular disease or CVD. The other one is colorectal cancer and the aspirin use to influence that. So here is what they said. They said, number one, they have changed compared to 2016 recommendations. They have changed the age range to start from 40. So when you would look at their recommendation, and when they say, all right, for this risk factor, it may be useful to have aspirin, they're starting from 40 onwards instead of 50 onwards. In 2016, they were going from 50 onwards. So that is one change. Second, in 2016, the group that was 50 to 59, now that group is 40 to 59. And secondly, the recommendation has changed from B to C grade. In the B grade, the recommendation meant to initiate the aspirin therapy, low dose aspirin therapy. Again, to look at all the risk factors. And if it is reasonable to initiate, then initiate it. The C grade recommendation, the change in recommendation is to say that number one, it's more restricted, that who should have it. And number two, it is per person. It is an individual and their doctor's decision. So it is not a general recommendation that if you reach age 40 and onwards, and if you don't have any bleeding tendencies or bleeding disorders, for example, ulcers and other things, then start aspirin. This is not the recommendation anymore. Now the recommendation is to sit down with the doctor, discuss if you have a risk factor for the cardiovascular disease in the next 10 years, and that risk is more than 10%, then initiate if other risk factors of bleeding are not present. So this is the C grade recommendation. In the 60 plus years, the recommendation has become D grade. And that is, it is not recommended to initiate aspirin use in 60 plus. In the 70 plus, the recommendation is I grade, which is insufficient evidence. So they're not saying yes or no, although you would see in the document that they would say it again and again that with the advanced age, the benefit of aspirin would continue to reduce because with the advanced age, the bleeding tendencies generally become more. And now, when we are giving aspirin on top of that, we are actually creating more harm or potential harm or risk of harm. So the risk benefit analysis does not yield a positive outcome or as significantly positive outcome as possible. So for 70 plus, insufficient data. 60 plus, that means 60 to 69, do not start. 40 to 59, individualized decision. And I'll discuss the criteria. Then for the colorectal cancer, they also say insufficient data for that. They don't have sufficient data, or they do not have data with the sufficient volume and significance to say aspirin helps with the colorectal cancer. So then, what are they talking about further, a little more deeper? So let's do this. Before we actually look at these populations, let's do an exercise of actually calculating the risk factor. So there are two calculators, and the links to these calculators are in the description. This is the version 1 and this is version 2. I'll show you both, although I would recommend that you use the plus. So version 1 says what are the risk factors and what are the variables here. Demographic, male or female, age, then race, white, African American or other, labs for cholesterol, then systolic blood pressure, and then personal history, that does the person has diabetes or smoker or treatment for hypertension going on. So I'm going to use their plus, and I've already kind of filled it a little bit for us. So put the age 53, that's my age, sex male, race other. So this calculator or estimator has a slight gap. So they have a good data for whites and African Americans, but not sufficiently good data for other races. So they simply have if you see here, if I increase the size, they simply have a note here that if you are not white or African American, then the calculator may not be exactly for you. Now, systolic blood pressure, I plugged in 100. Diastolic blood pressure, so this is the estimator plus. So this has a little more number of variables in it. Diastolic blood pressure, let's say 70. Total cholesterol, 256. So I'm kind of making it trend a little towards the border of normalcy, but above. High density cholesterol, also, it should be, let's say, in this particular test kit, 50 and plus, and here we have lower level. LDL 174, and that should be low, and it is high here. So slight abnormality in these numbers. History of diabetes, no. Smoker, let's say former 5 years, 10 years. I used to actually smoke when I was in medical college. I used to smoke when I came to US as well, although I don't smoke anymore. Hypertension, no. Statins, no. Aspirin therapy, no. And then you can refine it further. But anyways, when you do this, look at this top over here. It says 5.1% borderline risk. What does that mean? And this is what the recommendation is talking about. What they're saying is, in 10 years, my risk of cardiovascular disease with these numbers that I plugged in is 5.1%. And the recommendation is saying that if somebody is risk of cardiovascular disease in 10 years, that means this calculator is 10% or more, then the recommendation is C grade. That is, sit down with the doctor, look at all the other possibilities, bleeding disorders or not, and then decide to start using aspirin or not. So that means for the previous approach, where somebody who was 50 plus, they would just start a baby aspirin daily. That recommendation is gone. Now the recommendation is to sit down with the doctor, do the estimation, and then decide. So here, 5.1%. Lifetime atherosclerotic cardiovascular disease risk, 50%. Optimal ASCVD risk, 2.9%. So you can actually, I would recommend everyone here to at least do this calculation at least once for yourself and just have this data, just look at it. Okay, so now we know that what does this estimator do? And we have a number here, 5.1%. Now I'm going to go back here. Who is this recommendation targeted towards? The population. The population is 40 plus, but not all 40 plus. Those 40 plus who do not have known cardiovascular disease or suspicion of cardiovascular disease. If somebody had, for example, myocardial infarction, or somebody had, for example, hypertension or deep vein thrombosis or cerebral hemorrhage, then they have a cardiovascular disease. Then this is not the population, they're not included here. I wonder how would this mean those youngsters who are, let's say, messenger RNA vaccines, and they have myocarditis. That myocarditis is not really cardiovascular related, but that could be vascular related too. But most of the time it is autoimmune. Could that be, for example, clotting related? And would that then mean that they are excluded from this? So that's another, I think it's a clarification that would be needed from them. Okay, so that is a population here, 40 to 59 years of age. If the risk, the calculator that I just showed you, is greater than equal to 10% in 10 years, then grade C recommendation, they should sit down with the doctor. They should look at the remaining pieces, if there is any bleeding disorders or tendencies and so on, and then decide. So here, this is one more piece that I wanted to share with you. Treatment or intervention. The benefits of aspirin for cardiovascular disease prevention appear similar for low dose, lesser than or equal to 100 milligram per day, and for all doses that have been studied in CVD prevention, which were from 50 to 500 milligram per day. A pragmatic approach would be to use 81 milligram per day, which is most commonly prescribed dose in the US. So that is the low doses definition from their point, or a pragmatic definition. Now 60 plus, grade D, recommends against initiating low dose aspirin for the primary prevention. If somebody is 60 plus, never have had any cardiovascular disease, and now their doctor and them, they're thinking about using aspirin to prevent a heart attack or cardiovascular disease event, then the recommendation says do not start. 70 plus, as I said, grade I, insufficient evidence. Now, risks. There are two kinds of risks in that document. One is the risk of cardiovascular disease, and the other one is the risk of bleeding. The risk of bleeding, if present, will change the recommendation for the aspirin, because aspirin itself would potentiate or augment or increase that risk. So now cardiovascular disease risk, who is at risk? Men generally are more at risk than women. Advancing age, that is the biggest risk factor for cardiovascular disease. Race and ethnicity, Black persons are at the highest risk of cardiovascular disease. And then the risk calculator that we just looked at, the risk from there is also a risk to be cared for. Now, what are the bleeding risks? What are the risks that one has to make sure that they keep in mind, their physicians keep in mind before they start the aspirin? So, bleeding risk, intracranial hemorrhage, somewhere risk for the intracranial hemorrhage, or hemorrhagic stroke, again, bleeding in the or the hemorrhage in the brain area. It could be subarachnoid, it could be subdural, or intracerebral. GIT bleeding, for example, ulcers and bleeding from them. And then all of this increases, all of these risks increase with advancing age as well. These bleeding risks have to be kept in mind when starting aspirin. So then, harms of preventive medicine. This medicine, aspirin, what is the harm? So look, they said that we had many randomized controlled trials. Some of those trials went on for 10 years or more. And then they collected the data from them, from those trials, and then analyzed that data, created their simulation, and then they're coming back with this recommendation. So, bleeding harms. They're talking about the following types of bleeding, if I can make it a little bigger. Number one, total major bleeds. That is defined as a composite of intracranial hemorrhage, major GIT bleeding, or major bleeding from other sites. These together make up total major bleed. Why am I becoming so specific that I'm reading it from there? The reason is that this is an important recommendation, and we have to see the exact language that they're talking about. So this is the total major bleed and the definition of that. Then is the major GIT bleed, and they define that as gastrointestinal bleed that required a transfusion, hospital admission, or resulted in death. That is the GIT bleeds definition. Extracranial bleed outside the cranium head area, defined as major bleeding that was not intracranial, not inside the head, hemorrhagic stroke, and intracranial bleed. So then other hemorrhagic stroke and intracranial. And what are the intracranial bleeds? These are defined as hemorrhagic stroke, subarachnoid stroke, and subdural hemorrhages. And we can talk about these, but these are all within the brain's wallet, just different parts of the tissue. So these are the bleeding disorders that were looked at when these randomized controlled trials with aspirin were going on. So then they said, when looking at studies reporting on the harms that they talked about of low dose aspirin use, that is lesser than or equal to 100 milligram per day, which is most relevant to current practice, and pooled analysis of 10 trials, that is 119,130 patients, showed that aspirin use was associated with a 58%, check this out, 58% increase in major GIT bleeding, and they defined it up above. Look at this, 1.58 odds ratio. And the range 1.38 to 1.80, that means 30% increase to 80% increase range of GIT bleeding. A pooled analysis of 11 trials, so this had 134,470 people, again, a good number, showed an increase in intracranial bleeds in the aspirin group compared with the control group. And how much increase? 1.31 odds ratio, that is 31% increase. And the range, look at the range, 1.11 to 1.54. So 11% to 54% increase risk of intracranial bleed with aspirin usage. Then they say low dose aspirin use was not associated with a statistically significant increase in risk of fatal hemorrhagic stroke. So this may be in your mind that, okay, well, now aspirin is associated with GIT bleeds. It is associated with the intracranial bleed. Is it causing people, is it killing people now with these complications? So they said there is no statistically significant increase in risk of fatal strokes. So it is not causing death more than not on aspirin or placebo. However, this would change the quality of life. Data suggest that the increased incidence of bleeding associated with aspirin use occurs relatively quickly after initiating aspirin. This is very important. This is why doctor and patient has to sit down to decide to start or not, because as they're saying over here, aspirin's use is associated with relatively quick bleeding soon after the initiation of the drug. So that means as soon as let's say somebody decides that I'm going to start taking aspirin from today, their risk associated with the aspirin for bleeding is soon after the start. That is why it is important to sit down with the doctor. And data do not suggest that aspirin has a differential relative bleeding risk based on age, sex, presence of diabetes, level of cardiovascular disease risk, or race or ethnicity. What they're saying is aspirin doesn't have different risk propensity or difference because of race or ethnicity or diabetes. So the risk that it creates is similar with all those variables. Although the increase in relative risk does not appear to differ based on age, the absolute incidence of bleeding, so absolute incidence, and thus the magnitude of bleeding harm increases with age and more so in adults 60 years or older. That is why the recommendation that 60 years and plus do not start aspirin. Because of the very small number of fatal GIT bleeding events in trials and inconsistent reporting, it is uncertain whether aspirin use increased fatal GIT bleeding. So fatal cranial bleedings, not statistically significantly increased, but they are unsure about the fatal GIT bleeds. So then they say, for persons who have initiated aspirin, so this is important, for persons who have initiated aspirin use, the net benefits continue to accrue over time in the absence of bleeding event. If somebody has started aspirin and they have not bled, then the benefit continue to improve for them or accrue for them. The net benefits, however, check this out. The net benefits, however, generally become progressively smaller with advancing age because of an increased risk for bleeding, and modeling data suggests that it may be reasonable to consider stopping aspirin use around age 75 years. This is a very important statement. Then they're saying it may be reasonable to consider stopping aspirin use around age 75 years. Because the benefit, the tendency to bleed, so the cost benefit continues to change. Now, the last part that I want to do is look at the table, which is very interesting. So give me 1 second. Let me go there. Here, this is the table. I would actually recommend that you download this PDF and please look at this table, especially if you're a healthcare provider. This is a must to look at this table. Here is how this table is structured. If you see here on the left side, women And then there are two groups: net life years per 1,000 persons. So, is there any gain in years of life if somebody has started using aspirin? And net quality of life years per 1,000 persons if they started using aspirin. And then these numbers 7.5, 10, 15, 20, that is the risk of cardiovascular disease in 10 years with that estimator that I showed you in the beginning. So let's look at it for a second. Although, let me make a main point over here. They say that those with these yellow highlights, this is their highlights, not mine. Those that are in the yellow highlight variable area, aspirin seems to be beneficial for them. So now let's look at what are these, some of them. So let's start with women. Women, net life years per 1,000 person, 10-year cardiovascular disease risk, if it is 7.5% in 10 years from that estimator, then administering aspirin provides minus 2.6 life year benefit, which is actually a disadvantage. So it reduces the life by minus 2.6 years. And the range is minus 10 years to 4.7 years. So that is what they said, moderately negative to moderately positive. So that means if there is a woman who has this risk factor of 7.5 years, she should not start aspirin. Or the recommendation would be, as you saw, that that is sit down with the doctor. Initiation, so this is 40 to 49 years of age. If it is 50 to 59 years of age, then look at the number, minus 11.8 years. So 11 point, almost 12 years loss. And the range minus 18 to minus 5. So a definite harm. And then if you go to 60 to 69, minus 20, and minus 25 to minus 14, definite harm. 70 to 79, minus 15.4, and minus 19 to minus 11.8, definite harm. So this group here is not going to benefit from aspirin use. Actually, you're seeing that the benefit is negative. But if the cardiovascular disease estimator says 10% risk of 10 years, within 10 years of having cardiovascular disease, then if you see there is a benefit here. Who has the benefit? Not all groups. The groups are 40 to 49, 50 to 59, 60 to 69, and 70 to 79. Not all. First two groups, 40 to 49 and 50 to 59. That is why they said 40 to 59. Here there is a benefit of 11.4 years. And the range is 3.2 to 19.7. I'm not going to read them all. But if you say 60 to 69, even with the cardiovascular risk of 10% estimation, they still do not have a benefit. They have a negative benefit. That is, harm would occur. And same is the truth for 15 and 20 and so on. Same way to read the rest of it. So once again, in a bigger picture, they are saying that those cells that we have marked as yellow, if somebody falls in these ranges, then aspirin usage, grade C for 40 to 59. And you saw that D, 60 to 69 and 70 to 79. And 70 plus inconclusive. So that is the discussion. I hope it made sense. So the basic takeaway is not that aspirin do not use at all or start using. Number one, if somebody is already using it, this document is not asking them to stop. Other than 75 years, they said that may be reasonable to think to maybe stop. If somebody already has a cardiovascular disease event, for example, a heart attack or a stroke, this document is not for them. So if they're using aspirin, then they should continue using aspirin. This document is also not for someone who is already on aspirin. This document is also not for someone who already has a risk factor. This is for someone who is going to start new aspirin, and we discussed that the recommendations are there. So I hope it makes sense. Please like, subscribe, and share. And if you would like to support this work as well, there are some links in the description. The best and easiest thing is to just become part of Drbeen.com. I have 1,000 lectures over there from various doctors and myself. And I think the price is really reasonable. Under $100 price for 1,000 lectures is a very reasonable price. So you can take advantage of that. If not, there is links for, you can buy me a coffee, or you can use PayPal, or you can become a Substack member, or you can become a patron. With this, thank you very much. I'll see you on the Chit Chat channel. Let me very quickly share the Chit Chat channel's link here. You can actually search for it by just saying on YouTube, Cool Beans Cafe Live. And here is the link. I'm going to paste that link over here. I would see you there. And once again, smallest, easiest thing to do is to like. Thank you. Bye-bye.